afternoon, everybody. Today we are going to have our organ donation committee CME 8. We will have the welcome address by me. So this is regarding our organ donation committee activity, which is going on from January of this year. This is our organ donation committee, and this is the emblem which we have created. And every month we are having the topics. And this month we are going to have the eye donation topic. At this juncture, I welcome our President, Dr. Abul Hassan sir, for joining this program, and Dr. T. Sendamil Pari sir, the immediate past President sir, and Dr. P. Senguttuvan, the President-elect 2024, and Dr. K. V. Sridhar sir, the President-elect 2025, Dr. Karthik Prabhu, the Honorary State Secretary, Dr. Gauri Shankar, our State Finance Secretary, and the speakers of the day, without whom it is not possible. I welcome Dr. Mangala, the HOD in Arvind Eye Hospital, Dr. Prabhu Vijay Raghavan from Sankara Eye Hospital, and Dr. K.S. Siddharthan, the iMed Hospital, and the panelists of the today, our senior consultant, Dr. S. Balasubramanian sir, and the Professor Dr. P. Shanti Raj Mohan.
Thank you, sir.
See, now actually, on 13/8/2024, the World Organ Donation Program was conducted at Bharathidasan College of Arts and Science, where myself and Dr. Saravanan and Dr. Abul Hassan were giving nice talks about organ donation, and there were around 350 students who participated. And we have felicitated Dr. Sendil Kumar, who was very instrumental in doing 4 or 5 organ donation transplantations programs. And on 13th, in Namakkal, they have conducted a wide program. They have conducted a program for the Rotarians, and they have distributed pamphlets in the Ulavar Sandai, and also around there is a talk happened for the Nurunal meeting. And also there was a felicitation for the organ donors and their family, which has happened in Namakkal IMA. And IMA Vellore also conducted a program which was conducted by Dr. Maheshwaran in Varghese College, Vellore, Chemistry Department. There 100 students participated regarding the organ donation. And the IMA Atur conducted an exhaustive program where they have released a pamphlet, and they have issued the notice to the public. Around 160 students attended the program. And the organ donation awareness meet we are conducting, as we have shown it, that, and the handouts we have already released. And to increase the awareness, we are conducting the IMA. We are suggesting all the branch office bearers to conduct regularly the organ donation awareness meeting, and spend 5 minutes at least in each of their meetings. And to conduct the regional organ donation awareness workshop in the colleges, we are planning in the next month. We will be doing it. And we wanted to conduct a hospital coordination committee meeting along with the nursing home board people. And the Transplant is the organization which is helping the Transplant Authority of TamilNadu. And we are having this organ donor card and all those things to get the registration. This is the TamilNadu IMA website donation thing, which is available. And if you go to the imatn.com, you can register your name in the organ donor card and get it. And this is a Google form which we have created, which we are going to circulate among the all the people. This is one for the doctors, and another one which I have created for the public. If you click onto that one, and immediately it will directly go onto this website, and then you can register it, and then automatically it will come, and we will issue a card for that. And to increase the awareness about the organ donation, awards for the good performing branches with maximum donor registration in our website. Branch conducting maximum donor awareness meeting will be given during the state conference. And one important message I wanted to tell: in the first time in Ooty on 14/7/2024, the organ donation, organ retrieval procedure was done It was done on a 62-year-old person. The organ retrieval was done in Ooty, and the subsequent were transferred to the Kovai Medical Center in the Coimbatore and Ramakrishna Hospital in Coimbatore, and the eye was donated to the Sankara Eye Hospital. It has happened. This was the first time it is happening in the in history of Ooty. And as per the request from the IMS headquarters, Delhi requested all the branches to conduct the organ donation day program. I request all the 165 branches to conduct program. Now is that there are around 4 to 5 branches have conducted the program and already completed. I request all the branches to conduct the program whenever they are able to conduct the program and send the message to me. And this is regarding last right respect to your donor, which was done in the தானமாக பெறப்பட்ட பெண்ணின் உடலுக்கு புதுக்கோட்டை அரசு மருத்துவக் கல்லூரி முதல்வர் ராஜமோகன் தலைமையில் மருத்துவர்கள் செவிலியர்கள் மரியாதை செலுத்தினர். Like this, the last rights respect is being done in the government institutions, and that is happening recent days nowadays. சம்மதத்துடன் அவரது சிறுநீரகங்கள், கண்கள், நுரையீரல்கள் மற்றும் கல்லீரல் தானமாக பெறப்பட்டுள்ளன. Thank you. One more thing I wanted to tell. Actually, yesterday in KMCH hospital, there were 3 different organ donations were done. One is that they have done the liver transplant, another one is a heart transplant, another one is a kidney transplant. That's what they have done, and that is in the history. It is a record for them actually, and that is the thing I wanted to tell. Thank you one and all. Now I request our president to inaugurate the eye donation awareness meeting.
Thank you, Rajesh. Good afternoon, all my dear friends and Kosal and all my dear office bearer colleagues. The speakers of today's webinar, Dr. Mangala, Dr. Prabhu, and Dr. Siddharthan. In the panelists, Dr. Balasubramaniam and Dr. Shanti, and all my dear colleagues, participants of this seminar. At the outset, I congratulate the Organ Donation Committee, which has been spearheading this message of organ donation from January onwards. Continuously, we are doing this program. I hope that our people are very much sensitized, because I always say that this thing, transplantation is a very landmark development, milestone development in allopathy medicine or modern medicine. So it is our duty to carry that flag of transplant in a bigger way to the people, to our own colleagues, to the students, and the entire spheres of the society. It is our job, and we are doing exactly that. And also here I would like to congratulate the IMA branches like Namakkal, Athur, Vellore, and Erode, who have done the program the last organ donation day, which fell on August 13th. I also participated in a program in a college near Erode. There was an overwhelming response. People were immensely benefited. And I thank our faculties for sparing our time and energy. And all of them, I know very well, all have lots of skills and wisdom in this particular field of eye donation. I think this is a platform which daily extract their knowledge and wisdom and spread to our people. So ultimately, we will have an impact at the end of the year that the number of organ donors increase from our fraternity, from the society, from the students. And also, I wish Rajesh and Kosal and other office bearers of Organization Committee to organize a physical meeting so that the message will be more stronger, and then what we expect, like a number of organ donors pledging their organ also will be a kind of significantly increased level. I think the way we are going ahead would be achieving the goal of more organ donors from our fraternity. With these few words, I am very happy to inaugurate the seminar on eye donation today, and also wish all success for the Organ Donation Committee. Thank you very much. Over to you, Dr. Rajesh.
Thank you, President Sir. As per your wish, we will be conducting a live program and we will conduct a massive program. Since Dr. Saravanan is very vibrant in doing it, we will try to conduct in E-Road itself, sir, so that we will have a nice program, sir. Since E-Road is very central to all the places, we will try to bring more people and we will do the program, sir.
Sure, sure.
Thank you, sir. Thank you, sir. We will do it, sir. Now we invite Dr. Sendamil Pari, the immediate past president, sir. Sir is available, sir. Sir is not available. Dr. Sengutuvan sir told he is just now arrived from abroad, I think. Dr. Sridhar sir told he will be joining, sir. Dr. Sridhar sir. Dr. Sridhar sir is not there. Dr. Karthik Prabhu sir.
Dr.
Gunasekaran sir, Vice President sir.
National Vice President, yes.
Good evening, everyone. Respected President Double, Rajesh, the Organ Donation Committee Chairman, and all the faculties attending today. I am very much thankful and also congratulate Dr. Rajesh for conducting this 8th such program without any break from the January, as our President told, fully involving our members for the organ donation, different type of organ donation, what are all the organs we can donate. Finally, the massive program is going on throughout the country in the eye donation. Today, you are having the eye donation and eye banking program. And I think this will be very most successful one for the members to take up to the public. Also, through these members who are all participating today, they can take up this issue of organ donation to the public and spread the message of what is the use of the organ donation, how the patients benefited, like that. I wish the program all the success and continue the other 4 months also, different programs, not only this, you can repeat the same programs in future also with different faculties. Thank you. Thank you very much.
Thank you, Vice President, sir, for your enthusiastic lecture, sir. Thank you, sir. Now, I invite Karthik Prabhu, sir. Karthik Prabhu, sir. Gauri Shankar, sir. Both are not there. Okay. Now I hand over the session to our Dr. Kosal Ram, sir. Without Dr. Kosal Ram, sir, this eye donation program might not have come a reality. Now I invite Dr. Kosal Ram, sir, to conduct the program.
Thank you very much, Rajesh Babu sir. So as this entire organ donation, eye donation is one of the key brainstorming session launched by Rajesh Babu sir. He always keeps reminding during all the meetings, and so this time he wanted an exclusive program for eye donation. So today we have got 3 speakers who are very eminent in the field of eye donation, who are doing a lot of cornea work in Coimbatore. So I thank everybody for having come for this program. So we will be having three sessions today. First, we'll be having Dr. Mangala from Arvind Eye Hospital, Coimbatore, who will be speaking on the basic aspects of eye donation, and Dr. Prabhu Vijayaraghavan from Shankara Eye Hospital, Coimbatore, who will also be talking about eye banking and what are the strategies. And then we have Dr. Siddharthan, eminent corneal surgeon from IMED Hospital, Coimbatore. So who will be talking about recent advances in corneal transplantation. And we have got 2 eminent panelists today. One is Dr. Balasubramaniam from Ponnamal Duraisamy Eye Hospital, who is known to everybody as who has been doing a lot of eye donation work for almost 3 decades. And we have got also Professor Shanti Rajmohan from Government Hospital, Coimbatore Medical College, who will also be sharing all her insights about this work. So we'll go straight away to the program first. First, I would like to request Dr. Mangala to start the session. Before that, I'll introduce Dr. Mangala. Dr. Mangala is the head of the department Cornea and Refractive Services Arvind Eye Hospital, Coimbatore. She has got 14 years of experience in corneal transplant, infection, and various ocular surface diseases. She has got a good academic interest involving training fellows and has presented in several national and international conferences. We'll go ahead with the talk. Welcome, Dr. Mangala.
Thank you, sir. Thank you, sir. Thank you for giving me this opportunity. At this outset, I would like to thank the IMA team members, Dr. Abdul Hassan, Dr. Karthik Prabhu, Dr. Gauri Shankar, Dr. Sengatuvan, Dr. Rajesh Babu for giving me this opportunity, and also Dr. Koshal Ram and Dr. Siddharthan sir who gave me this opportunity. Without delay, I'll directly go to my talk. I'm just going to take you through the current Indian scenario in eye banking and where do we stand now. So why we are talking about organ donation? Because in particular about corneal eye donation is done only after the patient is dead, and we have a lot of patients with corneal blindness and waiting for a eye donation. So we need to focus more on eye banking and eye donation. Coming to the little bit of epidemiology, corneal diseases are the leading cause of monocular blindness in the worldwide, and in corneal diseases, corneal opacities are mostly caused by infectious keratitis. They are the third leading cause of blindness globally, bilaterally blindness. Nearly 10 million people are affected by bilateral corneal blindness. In Indian condition, it is the first cause in the age group of 0 to 49 and the second most cause in more than 50 years old, because after 50 years, cataract comes the first cause of blindness. So the most commonly performed transplant procedure done worldwide is corneal transplantation. So why we are talking about corneal transplantation? Because this is corneal diseases are avoidable as well as treatable. So these are the various causes of corneal diseases which causes corneal opacities and which ultimately leads to blindness. Here, few diseases can be avoided and few diseases can be treated with corneal transplantation. So coming to the demand, in India, in a particular year, we need 1 lakh corneal tissues for surgeries, but we do get only 25,000. So we can see how huge demand and in the procurement of corneas, and every year 25,000 more cases are added, which is also increased year by year. So the functions of the eye bank, it is a non-profitable, non-governmental governmental organization which functions for like creating awareness, tissue harvesting, tissue evaluation, tissue preservation, distribution, and also for research purposes. So this is a small clipping of eye donation activities. Whenever a patient is dead, the relatives go and give a call to the eye bank, and then the team comes and they get a family consent. Then they draw blood for the serology. The enucleation is done, and then the eye is sutured so that there is no cosmetically disfigurement. So then the eyeball is taken to the labs in the eye banks, and it is evaluated in the slit lamp. Then serology is done and make sure that no infectious disease is there. Then the corneal button is excised and it is preserved in the preservation medium. So after putting in the preservation medium, we do evaluate the corneal buttons and for checking the endothelial count, which will help us in grading the corneas, which will be used for surgeries. Then again, the corneas are evaluated and finally the transplants are done. So in India, the eye bank has a 3-tier system where we have eye donation centers, eye banks, and eye bank training centers. Eye donation centers, there are 2,000. They only give awareness talks and collect only the collection job is done in eye donation centers. Eye banks, they do the same job. Along with that, they evaluate, store, utilize, and also they transport the tissues to various surgeons. Eye bank training centers, they do the job of eye bank. Also, they train, teach, and do research activities. So, little bit of history about eye donation. This Edward Kim Zim, he was in Czech Republic performed the first penetrating keratoplasty. And in India, the first eye bank was started in 1945, and in South TamilNadu, it currently known as Regional Institute of Ophthalmology, Chennai, by Dr. R.E.S. Muttaya, he performed the first corneal transplant in 1948. The first eye bank in India was started in 1945 in RIO, Chennai. And the first program in the world, the National Program of Corneal Blindness, was started in the year 1976 by stalwarts like Dr. Govindappa Venkataswamy, Dr. Lalit Prakash Agarwal. and Sir John Wilson's. It was started for tackling blindness and visual impairment, aiming to reduce the prevalence of blindness from 1.4 to 0.3 by 2020. These are various landmark years where we had a lot of even say about banking. The National Eye Bank started. Eye Bank Association of India was started in 1989. Then Human Organs Transplantation Act was passed. In 2012, the Eye Bank Association of India partnered with the US-based SightLife to create a network between the eye banks and the surgeons and to improve the tissue accessibility national level. And many more acts were passed by the Indian government to help the eye bank activities. So this is a landmark act where the act was amended to include tissues in 2011, but it was published in the Gazette in 2014. The Transplantation of Human Organs Tissues Rules. This is very, very important act, after which the corneas were explicitly clarified to be tissues and were not to be treated as organs. And also the consent from the donor from the very close next of kin was extended to more relations so that they can take the decision after the death in eye donation. And also trained technicians can harvest corneas and who may not be a registered medical practitioners was also passed that year. So in India, we have voluntary donations and hospital corneal retrieval programs. So voluntary donation is entirely a social responsibility, and it is mostly towards a public awareness level. And in so many years of inception from eye banking, it has definitely increased. But more pledging happens, but only less donation is occurring, because unlike a blood donation, it doesn't happen immediately. People will pledge for eyes, but because eye donation happens only after the death. So what are the barriers or the difficulty in deciding at the time of the grief, and lack of awareness about donation, and somebody to motivate during that particular time to coordinate between the deceased family as well as the eye bank. In HCRP, it is in hospital corneal retrieval program. It was initiated in 1990. It was aimed to target hospital-based eye donations. The main advantage from this program is young donors will be available, and we can get the medical history readily, and quick retrieval is possible, and also to rule out other medical contraindications. So current trends in tissue procurement and utilization, if we see, there is a steady rise in collection and utilization. But if we go through the statistics, only 2% of the total eye banks, eye donation centers, only 2% of those are really contributing to 70% of the nation's transplant. There is no uniformity. And in only 14% of overall eye banks, they actively have a reporting system. So coming to the tissue utilization, 20 to 28% of voluntary donations only are used for are utilized, and it is very high in hospital corneal retrieval programs, which is around 50%. So this is a statistics of showing the collection of India from 2010 to 2020. We can see there was a target placed by the EBII, and almost the target was achieved. And when you see the utilization rate, we can see almost only 50% was utilized, because all corneas which we get cannot be utilized for various reasons. So this is the statistics as per Eye Bank Association from 19 to 24. We can see a small, not a small, great dip in 2021 because of COVID, and then again the collection and utilization has increased. And these are the 5 states top 5 states where eye banking is high, and TamilNadu stands first. So it compared to a few years back, now the utilizations are much better because of utilization of even a non-optical grade tissues like lamellar transplantation, where we can use a single eye for 2 surgeries, and also these eyes were used for research and improving keratoplasty training. But why we are bothered? Because it can be much improved, because of, it is low because of inadequate donor screening and absence or positive serology, bad handling, and infection, which is still are barriers for utilization. So corneal transplantation trends in India, more common cause of indication for keratoplasty, that is corneal transplantation, is corneal scarring and corneal infections. So corneal infections are the reasons behind more than 60% of people suffering from bilateral corneal blindness. The second cause is regrafts, which is the grafts which are placed for an active cases which becomes white after some time. So in India, the transplant surgery rate is 15 per million population, and as compared to cataract surgery, it is 4,000 per million population. So there are a lot of gaps between procurement and transplantation because we need to have a special body to govern the number of individuals who actually need, who are actually corneal blind, who have, and the number of corneas collected, and there should be a national registry for them to register, and the number of persons who have got transplanted, how many corneal surgeons are trained, and different types of keratoplasty so that utilization can be improved. So these are the various things which still is playing a gap between the procurement and the transplantation. So the challenges which in eye banking, the current in India now is still is going in social and cultural perceptions, because even now we have a lot of stigma in giving, and many communities and people, they have stigma in donating eyes. And coming to the tissue supply, so when we get 60,000 corneas per annum was collected few years back, but only 28,000 were used. There is a high demand, but the procurement is very less. So because of the COVID, again, we have short of 2 years, and then now the volume is much more. The backlog is also much more. So coming to the tissue retrieval, even we still now there are ill-trained, poorly committed staffs, inefficient operating protocols, technicians, grief counselors are still lagging. So that the first step, that is approaching the potential donor families, is still questionable. Coming to the workforce, and training of the corneal surgeons is very, very important, and it is still not very uniform the countrywide, and there is no statutory body to back up the training though. So this has also to be improved. Tissue distribution, there should be a network where they should be connecting the regions where there is high donation and where the people are in higher demand. Policy support, the government and the policies are there helping the eye banking and other people, but still there is a lot of issues in reimbursement and implementation of these policies. There is definitely a financial constraint in running an eye bank because there is no viable method for sustainability, but where the processing fees is more compared to the donation fees. So still there is a disparity between these two, and there is also a problem in maintaining quality standards. So coming to Indian scenario, there are a lot of individuals affected by corneal blindness, and there is an excellent infrastructure and readiness for corneal transplant surgery, and the surgeons are there in one side. There is a gap in between where the donors have to donate the eye so that this can be rectified. So this necessitates creating a strong and independent system to take care of the logistics factors in advancing technology, surgical and otherwise. So several steps have been taken by our nation, and thank you. I think after so many awareness programs like this, we may improve. My next speaker, Dr. Prabhu, he will be talking about how to improve the, these are the hassles we have, and he'll be talking about how to improve the corneal transplant. Thank you.
Thank you very much, Dr. Mangala, for sharing a very nice overview about eye banking and how it evolved. So as you are not, we'll come to the next talk. The next speaker will be Dr. Prabhu Vijayaraghavan, who is the Senior Consultant in Cataract, Corneal Transplant and Refractive Surgery at Shankara Eye Hospital, Coimbatore. A brief introduction about Dr. Prabhu Vijayaraghavan. He did his undergraduation from Coimbatore Medical College in the year 1999 and did his post-graduation MS Ophthalmology from Arvind Eye Hospital, Madurai, and has done a specialty fellowship in Cornea and refractive surgery from Arvind Eye Hospital, Coimbatore from June 2013 to 14, and then further which he was working as a junior and senior consultant in cataract IOL services as well as the corneal services. And he is currently working as a corneal surgeon in Shankara Eye Hospital, Coimbatore, and he has made multiple presentations, and he has which has won one of the best paper in ASCRS Boston, best paper of session in challenging cases in cataract surgery, and he has presented in multiple conferences, particularly attended even the ASCRS conference in the US multiple number of times, And over to you, Dr. Prabhu Jayaraghavan.
Thank you, sir. Respected seniors, and thank you, IMA, for the opportunity. Yeah. Thank you, sir, for the opportunity. So my topic is like about few of the do's and don'ts about eye donation, and a small glimpse, and as well as some important areas in how to go ahead and increase the eye donation. So I'm entering my topic. So as Dr. Mangla has clearly made it, so the commonest problems which we see, which we require a corneal transplant is mostly scar after an infection, or some we are seeing a lot of keratoconus patients right now, and genetic issues also which require a transplant. So this slide is my very favorite slide, which you use most of the time for all the presentations which I make for the public. Here it is not necessary, but it's okay for completion. So you can see that in case of a cataract surgery, it's a white, matured, and an advanced and complicated cataract. But you can see at the end with a good intraocular lens, almost something like a normal eye. But if you see in case of a corneal disease, where you can see the cornea is melted away and it is thinned out and is about to perforate, we don't have any other an artificial alternative to replace the corneal integrity as well as the metabolism. That is the most important thing. Cornea, something like liver, it has a lot of metabolism going on, and it is it is a big mystery. The working of the cornea itself is a big mystery. So it is not easy, and we don't see in the near future that we will be able to have something like an artificial intraocular lens which can eventually do a good job, something like that, of the intraocular lenses, which we have been using it for more than 30 years right now. So the option which is left for the corneal diseases is only the corneal transplant. And for corneal transplant, unlike any other organ transplants, living donor concept is not possible. So the eye donation of the deceased is the only option. And more important is early retrieval, because since it is not a living donor donation, we have to go for early retrieval. So these are the two important strategies we have to work upon. So some of the do's is as early as possible, like maximum within 6 hours, the eye should have been donated, enucleated, or the corneal button can be removed, and it has to be transferred into the if it in case of a corneal button, it has to be transferred directly into the medium, or if it is a whole eyeball, then it is for transport, we can use the moist chamber. So this all not required for the doctors. Like we know, with the eyes, we have the normal blinking mechanism to protect the cornea from dryness. Whenever the person is deceased and he is not blinking anymore, then probably requires to be closed and kept moist. So about the transport mediums and the storage mediums, previously we have been using MK medium for a very long time. For the somewhere in 2000s, early 2000s, we have been using it. But eventually, in the last 5 to 7 years, at least close to 8, 9 years, we have shifted to the cornisol medium, which allows us to keep the corneas metabolically very active between almost up to close to 1 week. So we are seeing that tremendous improvement in the research and infrastructure, so that right now the cornea which is donated in Kanyakumari can be even transported to Kashmir and taken for surgery within 1 or 2 days without having any compromise on the quality. Actually, the first day or the cornea, and the second day, the cornea behaves little more normal than the first day. That's what I think Dr. Mangla and Siddharthan would agree with me, how they function, they become. We usually transfer the corneal button and then wait for a day also, and then see eventually it functions little more. It becomes little more crisp, clearer, and it functions really well. And we also have a small introduction to the long-term storage mediums. We have now an option of glycerin preservation of the cornea. I think during COVID days, we had a very good experience that we did the glycerin preservation also. And it is structurally, it is a dead corneal tissue, and it is something like a plastic, but it can be used for many of the therapeutic keratoplasties where infections and perforations, where eventually, even if you do a normal cornea, it is going to fail. In that cases, even the glycerin preserved corneas have really worked really well, which either we can go for the retransplant a little later with a good quality. So the technology has gone to a very great level in preserving the corneas and transporting it and delivering it to the recipient end. There's no doubt about it. And we do have some glitches about the all the cases we cannot use the eyes because of the transmission. There is a high risk of transmission of HIV, hepatitis B, hepatitis C, as well as any kind of a viral encephalitis disease, or even suspected or a proven case of rabies or septicemias and leukemias, and any kind of an ocular infection or ocular tumor is the only contraindication. Systemic malignancies, when it is very localized and it's not blood spread, even so in US they have started utilizing the tissues. That's what we are seeing. So if it is a malignancy is well treated and completely cured, or if it's a systemic malignancy, very localized, not widespread, then probably we can consider using those tissues as well. So some of the myths actually is now we have seen many of the people who this is a common slide which I always discuss, is like sometimes the patient can be a patient who is diabetic or hypertensive, or he is where he had his retinal issues because of diabetic retinopathy, and he himself was not seeing properly. Sometimes the relatives and attenders might think that by donating his eye, we may not be useful for the community. That's not true. And even people who are not seeing because of the retinal issues or some other ocular pathologies, if his or her cornea is clear, even if they donate the corneal tissue, their cornea is going to work brilliantly well in some of the recipients. And the cataract surgery, post-cataract surgery is not at all a contraindication, because we nowadays the cataract surgery technology is very highly advanced. Even for a very elderly people with very hard cataract, we are able to do good job without doing much damage to the corneal endothelium. So the endothelial rates are way high above the transplant limitation rates. So even if it is a under cataract surgery undergone eye, we can take, or we can collect and utilize it to a maximum. And there's no religious or gender bars, as we all know. And post LASIK, the type of LASIK, like previously there was one type of LASIK called as a radial keratotomy. Maybe that those kind of refractive surgery done eyes may not be really useful. But in case of LASIK, now the whatever the type of LASIK we are doing, still the endothelium, if it is working really good, then probably yes, those people who have undergone LASIK may are also a good candidates for corneal, eye donation. So coming to what are the important areas where we have to concentrate on enhancing the eye donation. The eye donation perhaps has seen its trend change. Previously, the eye donation was mostly a home-based eye donation, where the organizations like Lions and Rotary and Youth Wing and small groups of common interest were helping us, and we are doing a great job for over long, long years. Still, right now, also about 30 to 40% or even 40% of the donations could be because of home-based. So these things has to be continued. and concentrated upon. But right now, as Dr. Mangla Madam rightly pointed out, the HCRP is a very new hospital cornea retrieval program introduced, and it's really, really doing well. And the hospital cornea retrieval program is doing really well, mainly because of two reasons. Like one, in the hospital setup, nowadays we can see that almost close to 80 to 90% of the deaths are somehow or other connected to any one type of a hospital, be it a tertiary care center somewhere in the center of the city, or to a PHC or a community center or a small block in the periphery in somewhere in the rural village also. Because the death certification is becoming a very important, vital role for the other human rights required for the deceased person. And then right now, the role of hospitals or the centers is becoming much more important, and it is becoming very connected. So that's a good move. So, and the government bringing in that move for a hospital cornea retrieval program is the key in the success of good collection. And moreover, um, hospital based or an ICU based platform is a very good platform for collection of the process of collection of the eyes. Because when we have ourselves gone for many a times for home based collections for the long years in early 2000s, and we have seen the difference. Like there will be hundreds of relatives, and there won't be a sterile situation, and even the doctors them ourselves will be very stressed out, and not much of lighting. It's not a well ventilated room. Attenders will be around, and the time crisis, people will be watching. They are all waiting for us, and we are waiting for their good situation, so for them to clear up. So many difficulties. So HCRP has totally cleared away all these issues and made a very good, easy platform and a very aseptic platform to collect the eyes. At the same time, the medical records are completely available, and staff assistance is very nice. And along with that, we have the recent blood reports and other things. And the next thing comes to my mind is the eye collection along with the organ donation is an excellent platform where you get very, very good and viable eyes, like viable endothelial counts. The hospital cornea retrieval program itself showed that the utility rate of the eye collection from the HCRP program is way better. I think it's close to 80% or something when compared to the home-based eye collections. In that HCRP, organ donation, along with organ donation, eyes are going to be really, really, really very good. So the endothelial counts are going to be really good. And this would be of more help when it comes to the transplant per se. So for me, the most important thing which I thought is like the whenever there is a death in the family, and then it is always very difficult to introduce the new concept of organ donation, I mean, eye donation to the family whenever the family is already in a shock, kind of a shock. So right now, but eventually we don't have any choice, but we do have to talk about it. So in such case situations, whenever it is a consulting doctor, whenever we are signing the death certificate, probably we can just put in a word to the attenders who are coming in for you kindly consider eye donation, because we can emphasize the fact that it is a life after death. So they always continue to see, but eventually after death also. So that is one point. Second, if in case it is a death happening in situations like hospitals, then definitely the ICU staffs or the doctors or the counselors or the senior nurses can always have information or a suggestion given to the first kin who is responsible for taking the decisions. Second. Third thing is like more than all these things which we have been doing, now I started feeling this slide becomes more important for me, because priming the priming the society when it is not affected by itself is the most important thing, which I believe right now. Because eventually, whatever we speak, once the situation is like that, then they are not able to really take a decision unless they are very clearly primed before. So eventually, throughout the not only in during the eye donation fortnight, probably throughout the year in a subtle way, maybe we will have to keep on talking about the eye donation, its usefulness, it is the way its simplicity in happening, and how is it useful for the other people. And we have to make the public understand that there is not much of a disfigurement seen at all, and there's no business involved in it. And Indian law does not allow the data exchange between the host as well as the recipient. All these things, if it is slowly talked upon in various ways over throughout the year, and the already primed mind is the one which is required right now to act faster and to accept faster and to take decisions faster and help us in case of situations which they knock their doors at their point. So how to do the priming is the most important thing. So we do have to have some amount of lectures or something happening in the high school level, and not in the very lower levels of the school education is not going to help us, probably in 11th or 12th. And the second most important thing would be to do more of a promotional programs in almost all the colleges. Maybe we can make a small uh, part or a small subset into their curriculum, that they have to know about the entire organ donation as well as the eye donation in the colleges, in whatever the spectrum of educational career what they are having. So that the young minds in the colleges are the minds which can make a lot of changes when it comes to the society, and the acceptance is much faster in them when compared to the other people. Third thing is like doing some kind of an awareness in the IT sectors and people where they are very advanced and they can take the things faster. We do have run a lot of programs for IT people to know about all these things. And definitely in our country, celebrity involvement is a big booster for anything. And already we have been doing such activities, probably a little more of celebrity involvement, things like that during the fortnight's time might help us. And nowadays, the concepts of old age homing is picking up well, and it will not be a very nice idea to talk about the donation and other things in the old age homes. But if we can do some kind of a balanced kind of the promotional activity into those areas is going to help us a lot. And as a routine, we should have a lot of posters and displays in the common public areas to prime the society. That's what would help, I think, from my personal point of view. And thank you for the opportunity. So I did not go much into the surgical aspects because Dr. Siddharthan is a pioneer, and in a lamellar as well as the full thickness transplant is talking about it. And I thank Kaushal Ram sir and the entire IMA president and other senior office bearers for the opportunity. Thank you, sir.
Thank you very much, Prabhu Vijayaraghavan. It was really a bird's eye view on how we can tackle this huge demand. All the points were taken, and there are more questions will come at the end of the session. So now I'd like to invite the final speaker of the day is Dr. K.S. Siddharthan, who is the Director, Cornea and Refractive Surgeon at iMed Hospital and Cornea Research Foundation, Coimbatore. He's going to talk on current advances in corneal transplantation. Dr. Siddharthan, as you all know, he's done his post-graduation from undergraduation from Rajamuthia College, Annamalai, and post-graduation from Arvindai Hospital, Madurai, and following which he completed his fellowship in cornea and refractive surgery in Arvind Hospital, Coimbatore. And from 2013 onwards till 2022, he was working as a cornea consultant in the cornea services of Shankara Eye Hospital, Coimbatore. And he has numerous awards to his name. To name a few prestigious awards, he has won the 3 gold medal awards of Tamil Nadu Ophthalmic Association, including the Captain Subramaniam Award, not once but twice, which was on eye donation one time, and the Dr. C.P. Gupta Gold Medal for the best scientific research in Tamil Nadu Ophthalmic Association. He has won the All India Ophthalmic Society Cornea Gold Medal Award in the year 2018, and he has also won the AUS IGOS Silver Award. And he has won an IMA award in eye donation, which was Dr. Rajashekaran Eye Donation Award in the year 2021 in the Tamil Nadu IMA conference held at Coimbatore. He's a pioneer in lamellar and keratoplasties, including DALC and DMEC, and he has done more than 900 DMEC surgeries from the year 2014 and, onwards, and he has also conducted a lot of DMEC training courses for corneal surgeons. So over to you, Dr. Siddharthan.
Thank you, Dr. Koshal, for a generous introduction, and I would like to thank the IMA for giving this opportunity. Dr. Abul Hassan Sir, State President, Karthik Prabhu, the State Secretary, Dr. Gauri Shankar, State Finance, and Dr. Sengotuvan, President-elect, and Dr. Rajesh Babu Sir, and Dr. Koshal for conducting this program. So my topic today is current advancements in the surgeries, but I just wanted to add that current advancements to enhance the optimal usage of corneal tissue. That's how we look at it. So just as Dr. Mangala and Dr. Prabhu have very extensively dealt upon, just wanted to add 1 or 2 points, because what has happened is in the recent years when they have taken a survey, about the organ donation, I think India stands first in the organ donation willingness, which is really shocking to see, because every time when we go, we see that we say that there is no awareness, there is no people are not ready to give. That is there, but still the awareness is there among the people and the willingness is there. So the only thing is we have to reach out to them, and that is what is more important. And actually, when they did a survey all over the world, they could see that the country of high readiness, India was really ready. So there is something that we have to do as doctors or the other people to connect this gap. So actually, this was very interesting. Actually, because other doctors are there in IMA. Actually, this is how organ donation people are doing. People who are brain dead, the doctors first. This is published in the Journal of the Cardiovascular Journal, where the first they go and ask when the patient is brain dead, they want to go and ask about the eye, how the family reacts. If the family is willing for the eye donation, then only they are going for heart, liver, and kidney. So this has been the published, and this is the public attitude survey. So I being the forerunner in this, but still there is so much of lag, as you have seen, and there are so much to be done. So as ophthalmologists, what we have done. So I'm not going to elaborate on very surgical techniques and all, but I'm just going to show what we have done as ophthalmologists to increase the utilization of the eye. So now the cornea has 5 layers. All of us know has 5 layers. So in the epithelium, now each layer we are doing component surgery. So the component corneal surgery is what nowadays most of the corneal surgeons are doing. Even Dr. Prabhu, Dr. Mangala, all of them are doing these procedures. We are doing all these procedures to help the public, because the tissue is so less. So we have to adopt new techniques to improve the utilization. So for example, the epithelium we are using for the limbal stem cell transplantation, and the Bowman's layer, the second layer for Bowman's layer transplantation keratoconus, the stroma per se for keratoconus patients in DALC, and the corneal allogenic intrastromal rings we use, and the decimates, where the 5th layer of the cornea is damaged, we use the endothelial cells. And then nowadays it is not done in India, but most of the place outside they are doing a cell culture, injecting the cells. So these are some of the ways where we are trying to help. So previously we used to cut the cornea into 2. The anterior portion was used for the anterior corneal pathologies. The posterior cornea was used for posterior corneal pathology. This was done many years back, even in 1950s, 60s, 70s, these were done. Anterior and posterior were used. But in COVID, when COVID came, all of us realized that that was not sufficient. And then the mechanism of microkeratomanol was not available. So when I was in Shankara, we used to separate the cornea, single tissue, for 2 patients. For example, we used to remove the 5th layer of the cornea, mark it, and remove it into a poor quality graft, and then this tissue is transplanted into another person. So for example, if this is a good tissue, the endothelial cells are good, we remove and keep it into a bad tissue which cannot be used. And this portion is used for one patient and this patient for one more patient. Again, during the COVID, we started using one eye for 4 patients and all, because there was no other options for us, because in COVID, there was absolutely no tissue demand. There was no availability of any tissue and the demand was very high. So we used to use the anterior portion of the cornea for keratoconus for first 4 layers, the 5th layer for any endothelial pathology, the sclera for any scleral problems, and the limbal stem cells for the limbal stem problem people. Just a short video, just to show a video, like how we mark the 5th layer of the cornea, and then we strip the 5th layer. So these are the techniques over the period of time, last 5 years, 10 years. Most of the surgeons in India, they have started doing this because there is a dearth of tissue. You can see that the 5th layer of the cornea is separated, and the 5th layer is separated and it is marked, because once we take it out, it will scroll. It is so thin. And this is from the poor tissue, where the tissue we don't use, because this tissue sometimes, as Dr. Mangla was telling, 50% or 30% only utility. So these tissues can be used. What I do is I remove this good quality button, the endothelium, and put it into that poor tissue to be transplanted. And then this tissue is really spread so that it waits to be done for the next patient, because there are 2 surgeries posted, because as I told you, 2 patients are available. So this layer is marked and it is kept. This is the other tissue which is good, where the 5th layer is removed. Only the first 4 layers are there. So this patient who has a keratoconus, the first 4 layers we are replacing with the good tissue. So for one tissue, we try to maximally utilize the tissue for these patients. So as we do this, as I showed you, the 5th layer is waiting for another patient. So once the surgery is done for that patient, we come to the second tissue. We have marked the size of the tissue, and the tissue is removed, and it is stained, because it's so thin. Actually, it scrolls into like a cigar bundle. So we should take it and inject it into the patient. So this patient has a 5th layer problem, and we are trying to open the tissue and trying to attach the tissue. So by this way, one tissue we are used for one young patient for a keratoconus, and this is another patient who is having a endothelial problem. We have transferred. So these are some of the methods what we are using. So now what we do is the same way. When we remove this tissue, the same tissue, what I do sometimes is we make a small opening. We make a small opening for marking. The same tissue can be used. As I told you, we can use it for the 5th layer. And then this small portion, of the tissue, which is going to go waste, even that small tissue, we take it for a patch graft, meaning a patient who has an infection and the cornea has become thin. We use this graft for these patients. So as ophthalmologists, we are trying to do what we can, means that we are trying to utilize each and every bit of the tissue so that there is no backlog. As you saw, so in the first speaker, Dr. Mangla telling that there is so much of backlog. We need about a lakh of tissue every year, but we are hardly getting 30,000-40,000. So this is one way we are using. So there are so many methods. Here another patient, the same tissue, as I showed you, we have made a hole, and this posterior layer is used. So one half of cornea, instead of going waste, we are using it for another patient who has a crescent-shaped corneal problem. So the same tissue, which I've already used for 2 patients, the third patient can also be benefited with this. So we have been trying to use as much as possible, because the deficit, it might take quite some time. So by doing this, we are able to utilize a single tissue for 3 to 4 patients. You can see that it takes a lot of time, it takes a lot of energy and everything, but there is no other go, because the patients need it. And in keratoconus patients, again, we can sometimes, when there is a small pocket to be done, when the patients are having very thin stroma, as I told you before, the stroma alone, after removing the anterior portion and the posterior, after doing for 2 patients, you can actually insert it into the, after making a pocket with a laser, we can insert the tissue. So this tissue again, the epithelial layer can be used for limbal stem cell transplantation, and the posterior layer for the endothelium, and the central layer for this. Even for the localized thinning, suppose for example cornea's localized thinning is there. There also we utilize, see for example the central portion of cornea we use for a full thickness graft, but the periphery of the cornea we just throw it away. So that patient, that cornea we sometimes keep, and we try to cut the cornea according to the shape of the defect where there is thinning. It takes quite some time, but we have no other alternative because we have to maximally utilize the tissue because there are so much of deficit in the pay for the patients. So you can see here, it's all most of the time hand fashion. We usually hand fashion this however we want, and then we insert it into the for the patient to strengthen that portion. So all these tissue otherwise would have gone waste. So and this patient would have been waiting for many months and years. So we have now devised these techniques to do this thing. And another thing is the limbal dermoid. Actually, dermoid, we would have seen many patients having this dermoid problem. So in this cornea, in this patients also, we try to remove the dermoid, corneal dermoid, and just an anterior lamellar portion of the cornea is more than enough. You can have used 1 or 2 layers for other surgeries, and this layer we usually keep it. As I told you, just the anterior portion is used. I'm marking around 100 microns, and then just you see that, and the rest of the cornea you can use it for whatever you want. Just the 100 mm, the 100 microns of cornea of the anterior layer is used for the this thing. So these are some of the techniques we keep adopting and changing, so that this is an artificial anterior chamber. So you can see that we use it for the patient. Otherwise, we need a fresh tissue to use. This is a used tissue we can use. And also, this is a limbal stem cell transplantation. After using the tissue, we store the tissue. And this is a patient who has had a limbal stem cells deficit. We are removing the corneal layers. And you can see this is the limbal stem cells. You can again see the center portion of the cornea is used. We're taking the limbal stems from the donor, and then we keep it over the cornea for the development of the epithelium. So again, this tissue otherwise would have gone waste, and the patient would have waited for many more months. And this again, we attach it with glue. We don't use any sutures for the, and then apply a contact lens. And then nowadays, because there is not much of tissues, now we are trying to adapt contact lenses, because in the 5th layer, there are some issues where there is so much of deficit. The patients complain of pain. So before we used to do a laser or a cautery and completely cauterize and make the cornea burnt. So nowadays, these patients keep waiting for a very long time for tissue. So these patients, what we do, we use a contact lens. The contact lens will prevent the water clogging of the cornea. So we sometimes utilize, remove the 5th layer. And since we do not have a tissue, there is so much of deficit, we use this is a specialized contact lens, which can be used on the cornea. This is inside the eye. So we keep it, we inject the contact lens, and this contact lens is attached with air. You see, we inject and position the contact lens, and then do. So all these, so many variations we are doing, because there is no other options, and I hope that all of us, including doctors in any field, would definitely help us to improve. So as I showed you before, nowadays used for one layer or first cornea, the anterior portion to one patient, posterior to one patient, limbal stem cell transplantation, sclera, and even for retinal surgeries for buckle, there some people are using. So generally, to conclude, the eye banks, what we are doing nowadays is there's a big waiting list. So we segregate the patient into clusters, meaning that depending on the diagnosis. For example, we have to have a waiting list for anterior lamellar surgeries, posterior lamellar surgeries, for limbal stem, like that. We have to differentiate the patient, and once you get the first the tissue, immediately you call the patient from the first list. For example, the anterior lamellar first person, the posterior lamellar first person, for the limbal stem cell, like that. You have to aggregate in our eye banks according to the diagnosis. So to finish the talk, generally what we have seen is, as ophthalmologists, we've experienced many families, because when they come to give, when we give them the certificate for donation, they feel very happy. At that time, they will say, "Doctor, good that you told us that time we were not really aware, but we are happy now that eye lives somewhere. Somebody is able to see. So they are seeing a good beginning in their lives, and also they have to understand that gives to not only the sight, gives lives for people. And I think we have to stop talking about the barriers of collection, and we have to move forward because the patients are ready, the public are ready. We have to take different strategies to do it. And I think with all our effort, I think we will be able to achieve this. Thank you.
Thank you very much, Siddharth. That was indeed a very apt talk, and we nicely summarized how tissue can be utilized for 5 different individuals. And so that because this is one way we can now act upon. So next we'll go to our panelists, Dr. Balasubramaniam and Dr. Shanti Mohan is there, ma'am. And sir, can you? And there are a lot of questions happening in the chat box as well.
Good evening. It's very nice that a meeting has been arranged for eye donation. And it is because I thank Dr. Abul Hassan sir, Dr. Kaushal Rao, Dr. Karthik Prabhu, and all the Rajesh Babu, and all the people who have made this possible, and all the speakers who have come voluntarily to speak on eye donation. Dr. Mangala talked about there are a lot of difference between supply and the need that has always been there right from the time of eye banking. The supply has been little and the need has been more. So how to circumvent it, Dr. Siddharthan has also highlighted it. And Dr. Prabhu has talked well on how to prime the mind for the eye donation. That is very, very important, because when you talk about death, everybody is not prepared to listen. But then we tell them, suppose you take a LIC policy, you take, because after my death, so my kids and kin will get so much amount will get. So we take LIC policy. So why scare about death? Even after death only, we are going to donate our eyes, which will be utilized. But then now, not only the eyes, even the skin is utilized for transplantation. They use it for all the burns cases and all. So it's very important that everybody is aware of these organ donation. Is very, very important. Siddharthan has nicely talked how to utilize the tissues for because of dearth in supply, how we can utilize it for various conditions, so the eye harvested doesn't go a waste. That's very important. So we have to bear in mind that the eye donation has gone a long way, and Coimbatore have been a pioneer. Sankara Eye Hospital started the first eye donation program in Coimbatore, along with my co-founder, Dr. R.V. Ramani, and we were able to make a mark in Coimbatore on eye donation. Now it has picked up, and this tempo should be kept up so that all throughout the year we will get corneas or corneal surgeons to operate. And there must be close contact between the eye banks and the corneal surgeons, so that whenever there is an excess tissue, we can send it to corneal surgeons who are doing the work. So it should be a close rapport between the corneal surgeons and the eye bank, and it will go a long way in helping the public to see better. These few remarks that I wanted to make. And this harvesting of the cornea, especially near the ICU unit, is a very, very important, because hospital retrieval program has picked up. It was first encouraged in Hyderabad, and later it spread to other institutions. And hospital retrieval program has done very well. And the family physician has got a role to play in this, because the patients always usually listen to their family physician. So after death, if the family physician suggests, so it has anything inevitable has happened, but if you can donate the eyes, it will be a nice thing if he tells a word, and it will be definitely be taken up by the relatives, and eye donation will go a long way. Thus, I think this is a very important thing that one should bear in mind. Thank you all for the opportunity.
Dr. Shanti, madam.
Yes, sir. Good evening, sir.
Yes, madam.
Thank you, IMA TamilNadu Chapter and Organ Transplantation Committee, sir, for organizing such an inspiring and impactful talk on eye donation. So all three are pioneers, and they are doing a current best job in the city. Regarding Dr. Mangala Madam's talk on current Indian scenario, she has shed light on the noble cause for truly changing the lives of the blind. So for people who are blind, I think even a vision that is going to be 366 by 60 is going to be very useful for mobilizing, for moving and doing their daily activities. But much needed of this moment is the backlog, as Madam has pointed out. So when there is a necessity and need for 1 lakh, we are just doing 25,000. So I think this gap should be filled. But as Prabhu Vijayaraghavan sir has pointed out, there are a lot of people who are willing, but then they don't know what possible way. Even I think medical fraternities, they have a lot of doubt on the basic problems regarding eye donation. So, but now the hospital retrieval corneal program, I think it has done a good job. And here there is a very pretty thing, like we know what the patients are, and the indications and contraindications are clearly said. So, and the quality of the tissue also here is good. So I think hospital retrieval, I think we will have to concentrate, and all the hospital management, they should more come forward in doing eye donations in their patients. So right in the entry, maybe they can take up for eye donation. So in the latest technique, as Siddharthan sir has wonderfully explained, the current advancement, and thanks to COVID for that, because it has shown it that layers of the cornea can be used, all the layers. So if one eye is used, that can be used for 5 patients. Like every layer can be used: epithelium, stroma, descendants, endothelium, and even the sclera. So these things should be imparted into the young brains, and the loss should be even more loosened, because there is a lot of thing regarding this eye donation legally, and this makes people worried, and this makes hospitals like not enter too much into this. So I think if like IMA could do something on the legal impact and the procedure, easiness of the procedure, that will be a great work. And we do have an MOU with Aravind, and here in hospital retrieval in Coimbatore Medical College is picking up. So thanks for the opportunity, sir. And regarding few questions that were in the chat box, there was a question regarding the age group. Is there any young age or old age which is a contraindication? I think there is no age bar. Only thing is, if it is too advanced age and with a lot of corneal pathology, I think then we would avoid. Otherwise, age related, there is no contraindication. And viral diseases, HIV and slow viral diseases are the contraindication. And someone has asked for absolute contraindication, which is again now all the contraindications like malignancies and other things which were previously thought is like now coming off. And only when there is an ocular malignancy, a slow viral disease, or a HIV, those things are absolute contraindications. Otherwise, the eyeballs are taken. And then there is one more thing for research purpose and academic interest. So if this cornea is not going to be used in patient, young doctors and people who are aspiring can always use it for the academic purpose. So that is one way of good thing where the corneal tissue are used for people to learn. So thank you, sir. It was a very nicely organized program. And if some light can be thrown to the youngsters, this is a great thing. Thank you, sir.
Madam, there are some questions which was actually sent by Dr. Sundaramurthy. He is a pulmonologist. He is very much interested in putting questions. One question is the role of stem cell therapy and cloning as a replacement for eye donation. Role of stem cell therapy and cloning as a replacement for eye donation. Anyone
Yeah,
want
that
to
is all
answer?
on the way, sir. So maybe in few years that would happen. So there is something called the cornea that can be done, or an artificial cornea that can be manufactured or produced. So all the process on the way. I think soon it will happen.
Then another question is, how successful eye donation for lazy eye disease?
For lazy eye disease, that is not a thing to do with eye donation, sir. So that is an amblyopia, that we call it as amblyopia, or unused eye, or the eye that doesn't take up good power. So that is entirely different, and it is not going to be useful for lazy eye.
Then another question from Dr. Sundaramurthy is voluntary eye donation common in urban or rural, male or female?
It is more common in urban, I think, sir. And regarding male-female ratio, I think it should be equal, because even though volunteers more are male, but then when it comes to the real disease, so here we don't take a live donation. So deceased willingness, it is equal in male and female, sir. And more so in female than male.
The main aim of this eye donation program and thing is that from the organ donation committee, every month we are conducting each and every one organ. We have completed so many organs. Liver last month, before that heart and lung, before that skin and kidney, and rules and regulations for organ donation. Everything we are doing one by one, we are coming. Since this month, it's a glaucoma week is coming from next week onwards, I thought we will conduct an eye donation camp meeting this month. That's why I have included in this. Then the main, the one question there once again is tuberculosis contraindication for eye donation?
No, sir, tuberculosis is not a contraindication, but if it is an ocular tuberculosis, a proven case of ocular tuberculosis, then we might differ, sir. If it is a tuberculosis of chest, then it is not a contraindication.
Then, madam, nowadays, the even in kidney transplantation, people are used to transplant people with HIV and HCV. All these things are there transplanting. Whether
Yes,
it is really contraindicated, HIV, HBsAg and HCV are contraindicated really. That's what I wanted to clarify from this group of audience, because all ophthalmology stalwarts are there. I want to have a clarification for our IMA people, whether the HIV, HBsAg and HCV, all these things are real contraindications for eye donation or can be taken.
It is an
Because you are
absolute
taking,
contraindication, sir.
sir?
It is an absolute contraindication, sir. HIV, a non-HIV patient, or a hepatitis B infection or a carrier, or a HCV infection or a carrier, slow virus disease, and rabies are absolute contraindications, sir. There is no, we need not take the donation itself in these cases, sir.
Sir, that's what, sir. But in kidney and other things also, they are telling they can take. That's what my doubt, sir. When
Really
they are
not.
accepting, when they are accepting it, why the rule has not been changed for the eye? That is what, because they are telling for the kidney also they can do it. For HIV
Okay.
and HBsAg people, you need to discuss among
Relook
your
into it.
ophthalmology colleagues, sir. Because this point, I wanted to clarify, because as such, the kidney, they are telling we can take HIV, HCV if the organ donation is coming. They are telling like that. So
Okay.
you need to have a discussion among your next conference like that. You have a detailed discussion and come out with a solution. And if anything new has come, you please inform us, sir.
Sure, sir.
That is the main thing, sir. Because of this HCV, HIV, and HBsAg. That is the thing, sir. Then
as Dr. Prabhu told, sir, it's absolute contraindication because even the tears has HIV and the aqueous, everything, sir. And because eye is directly connected to the brain, because the immediate infection can go to the retina, optic nerve, and can cause immediate death, sir. We will discuss, sir. We will discuss, but it's an absolute contrary. Even rabies, sir. You won't believe we had one death. One patient, we did a transplant. After 2-3 months, she came with headache, severe headache. She came to the hospital. She was lying down. Everything was okay. Then what happened is after 1 week, they called and she said she passed away. Then when we went and saw that it was a dog bite, rabies. So it was actually very tragic, sir. I donated, I had a rabies. They should not have taken, but they didn't know why the patient died. So we will discuss, sir, but still these are absolute contraindications.
And with the ample amount of tissue available, we don't have to take that risk of infections. And two things I wanted to emphasize here, sir. If you compare the difficulty, it is a fine art surgery, definitely. When it comes to the morbidity of the patient or to the mortality of the patient, it's way improved. The corneal transplants are way improved when compared to the other organ transplants. Maybe if in the future, maybe DMEC is a 10 micron transplant. If everything goes well, we can make it as a daycare procedure also. It's advisable to have at least 1 day of admission, but it can be done as a daycare also. Daycare. So maximum amount of transplants we can discharge the patient in 1 or 2 days. And more, the second thing which I wanted to emphasize is that the cost involved in the long-term maintenance of the corneal transplant is much less when compared to the transplants for the other systemic transplants. Here, even a 10 rupee or 20 rupee dexamethasone eye drops can do wonders in maintaining the corneal clarity for years together. So follow-up maintenance, everything is much easier. The one and the surgeons are all well trained. As Siddharth sir pointed out, the willingness for the public is already there, and then probably we have to do something to put everything into action, sir. And one more thing is like when many times we have seen there is a lot of delay in the RTA or the medical legal case involved cases for the eye procurement. There are a lot of formalities and signing and approvals involved. If as a general body with so much of influence and power, if we can shorten that, that is going to be of great use for the endothelial availability and usefulness of the graft, sir.
Good.
Sir,
Corneal
then
transplant-
another doubt is,
Small too, sir.
the
Rajesh,
people.
Rajesh, on a small intervention.
Yes, sir.
Yeah. Regarding the last question and the discussion following that, I think every faculty emphasize the importance of organs to be available, make available. I think the purpose of this committee and this webinar, beyond educating our people, beyond educating our society also, I think it has to convert into a movement. Unless a movement with the participation from all concerned, I think the same status quo will be there. I think there should be a jump in the harvesting of organs decade by decade. There's not only jump, a huge leap must be there. That I think we have that kind of responsibility. And Rajesh planned a kind of event at the end of the year, a huge event where there are people from the society, leaders from the society, leaders from various walks of life participate. And let us give a big flip to the donation of organs. I think particularly eye donation is very simple and doable by everyone. I think we have not obtained that kind of momentum. It's a very sad set of affairs. I think we should mobilize support for this cause and bring it as a movement. I think we can name it also, name the movement also, so that not only doctors and the society will participate. And I am very excited to know to see the photographs and this thing. There's more messages today. than other programs, and I am very happy. Thank all the faculties for sparing your time and energy.
Sir, actually, what we are doing is, whatever the recordings are coming, sir, we are converting everything into a YouTube,
I
and
know,
we
I
are
know.
releasing the YouTube, and it will be educating to our public, sir. That is the main thing, sir.
Yes, yes.
The another thing is regarding this eye donation, we have to train a huge number of people, sir. Yes, they were telling
I
they have got
harvesting
a
now.
eye harvesting, sir. They are having a law also that I came to know now only from the Mangla madam talk. Everyone can do it as per the law. So what we can start doing now itself is we can start training the paramedical staff in huge numbers, and along with the ophthalmologists who are really interested to get the training, so that we will train them in huge numbers, and then subsequently we will propagate the message to each and every village, because each and every village we will select some people and we will train them. We will do it, and we will get a large number of eyes, sir. That is the main thing, sir. Aim of doing it, sir.
Yes.
Yes, sir.
Sir, at this juncture, I just wanted to add few things which we are talking. One thing is, the less the age, the better quality of the eye will be, sir. So that we have to aim. And then, as you told, we have to train more persons for eye procurement. And the loss, sir, the medical legal cases will be young patients. Their eyes will be much more useful for surgeries. So we have a lot of pitch in that area. So as Dr. Prabhu was telling, if that can be made little bit liberalized, then we can get much more good quality corneas for the purpose. Thank you, sir.
I don't think there would be a big hitch there. I think easily it is overcomable, and we will take it up, madam.
Thank you, sir.
That should not be a big issue, big hurdle for procurement of eyes.
Okay. Thank you.
Madam, since you have told that the younger age eye is very important because of the road traffic accident people, we will have to discuss among the heads of the institutions, medical colleges, where we are getting more of the injury patients, and they are dying every day. Every day minimum there will be around 4 to 5 people are dying in each and every
Exactly, sir.
government institution. If we try to take that eye itself by training the people and get a clearance from the forensic department and also from the dean,
From the
we will have lot of eyes, madam. That is the main thing. And another main target is the village. We are doing the corneal transplant and eye donations only in the cities only. We are doing it, madam. We are even not going to the peripheries.
Yes, sir. Thank you all for attending the program.